week of June 8, 2026. Welcome back to Max's EM Weekly Update, the quick-hit podcast version of what's worth reading in emergency medicine this week. The goal is simple: less noise, more signal. This week, return visits, strep throat, epigastric pain imaging, 2 septic shock papers, and what we actually know about ambulance offload delays. Let's get into it. Our highlight of the week is a thoughtful EM Ottawa piece on ED return visits by Dr. Singh. The central idea is simple but important. Most return visits are not errors. In using bounce-back rates as a quality metric, or worse, a competency metric, is methodologically shaky. That rings true. A patient can come back because the disease evolved, because access to follow-up failed, because symptoms worsened despite appropriate initial care, or because the patient simply felt safer returning. Those are not the same thing as a misdiagnosis, but the raw number treats them like they are. The article also gets at something emotional that most of us have felt. Few phrases hit harder than "your patient is back." But a return visit should prompt reflection, not automatic shame. The practical takeaways are solid. Recognize higher-risk patients at disposition, address abnormal vital signs before discharge, and make your reasoning visible in the chart. Bottom line, many, maybe most, ED return visits are not mistakes. Bounce-backs can still be useful for learning, but as a blunt quality marker, they probably measure far more noise than signal. Next up, from First 10 EM, should we treat strep throat? Justin Morgenstern walks through the evidence behind routine antibiotics for gasopharyngitis, and the evidence base is shakier than many of us were taught. The benefits are pretty modest. Symptom duration improves by only about 16 hours. The number needed to treat to prevent suppurative complications is high, and in most developed settings, rheumatic fever is now rare. That does not mean antibiotics are never appropriate. It means the decision should be more deliberate. Local rheumatic fever epidemiology matters and patient preferences matter, but this should sound less like reflex prescribing and more like shared decision-making. Bottom line, if you have been treating every positive strep test automatically, this is a good reminder to slow down and ask what benefit you are really buying. For guidelines, the ACR updated its appropriateness criteria on epigastric pain.
For uncomplicated GERD or suspected peptic ulcer disease without alarm features, imaging usually is not appropriate up front. This document mostly clarifies rather than disrupts and gives you citable backing for 2 common moves: getting CT when perforation is on the table and not reaching for imaging in low-risk dyspepsia. Bottom line, useful guidance, probably not practice-changing, but helpful when you need to justify either imaging or restraint. Now to adjacent specialties. The first paper looked at refractory septic shock, using consensus clinical criteria, norepinephrine equivalent above 0.5 micrograms per kilogram per minute, plus a lactate above 2. In a large multi-center retrospective cohort of over 15,000 septic shock patients, about 1 in 5 met refractory criteria. Mortality in that group was 64%. That is sobering, though not exactly surprising. The value is not a magical new threshold. It is a shared language for a very high-risk subgroup, which helps with ICU handoff, prognostic framing, and goals of care conversations. Important caveat, this is prognostic, not prescriptive. The second paper is the one more likely to change real-time behavior. In neutropenic sepsis, delays to antibiotics mattered. Compared with antibiotics given within 1 hour, delays of 3 hours or more were associated with higher mortality, and even the 1 to 3 hour group did worse. The effect was strongest in patients with shock and hematologic malignancy. That is a clean clinical reminder. Febrile neutropenia is not a will-get-to-it diagnosis. It is a door to antibiotic emergency. Every hour matters. And finally, a systematic review on ambulance offload delays. This is a great example of separating conviction from evidence. Offload delays were consistently associated with longer ED length of stay. No shock there. But evidence for mortality harm was inconsistent, and only 4 observational studies met inclusion. So the right takeaway is not that ramping is safe, it is that the clinical harm, while very plausible, has not been studied well enough to quantify with confidence. That matters when we advocate. Fix ramping, but do not overstate what the current evidence proves. So here's the wrap-up. Return visits. Reflective, yes. Reliable quality metric, probably not. Strep throat. Routine antibiotics deserve more skepticism than they usually get. Epigastric pain. The ACR guidance mostly confirms current practice and helps support selective imaging. Refractory septic shock. 1 in 5 septic shock patients meet criteria, and prognosis is grim. Neutropenic sepsis. Time to antibiotics really matters. and offload delays, the system problem is obvious, but the mortality evidence is thinner than many assume. That's it for this week. Read critically, chart clearly, and keep separating signal from noise.
Before we wrap, here are 3 practical shifts I think this week's reading pushes us toward. Number 1, be more explicit about uncertainty and reasoning. That thread runs through the return visit piece, the strep article, and the offload delay review. In all 3, the problem is what happens when we flatten messy clinical reality into a simple metric or a simple story. Return visits are not automatically bad care. A positive strep test does not automatically equal meaningful antibiotic benefit. And ambulance ramping almost certainly causes harm, but the evidence has not yet pinned down that harm as cleanly as public discussion sometimes suggests. In each case, our job is to think clearly, document clearly, and speak precisely. Number 2, separate prognostic information from treatment targets. The refractory septic shock paper is a good example. A norepinephrine equivalent above 0.5 plus lactate above 2 identifies a population with terrible outcomes. That is useful. It helps frame urgency, escalation, and goals of care discussions. But it does not mean that chasing the threshold itself is the therapeutic goal. High-risk markers are not always actionable targets, and emergency clinicians need to keep that distinction sharp. Number 3, when time matters, really act like time matters. The neutropenic sepsis paper is the clearest example this week. If a patient with possible febrile neutropenia is sitting in front of you, antibiotics should move from task list to priority, not eventually, now.